Sorry, Professor Chao, pardon me, Senior Consultant Hepatologist 10, Tock Seng Hospital. Please proceed. Thank you.
Let me share my slide first. Can you see my slide?
Yes.
Okay. Thanks, Prof. John, for your kind introduction. And I would like to actually extend my gratitude to the Task Force for Global Health to invite me to give this important talk from the perspective of Singapore. This is my disclosure. And I once asked Professor Vincent Wong from Hong Kong on how we could actually measure hepatitis C diagnosis in the country for the program. And I'm glad that the WHO has also recently published a guidance for country validation for viral hepatitis C elimination. And in terms of the validations, we've done in the several domains such as hep C transmission, liver-related mortality, programmatic targets, and also prevention target. So it's just come time to be handy to me and to many of us, I think. And today, I would choose to actually focus on the programmatic the targets in the treatment and what is actually the Singapore progress and also the insight. I summarized the landscape of hepatitis C microelimination effort in Singapore today, and we have some plan for the outreach programs for other key population apart from the PWIT group, in which we have been working on for quite some time, and I have been heavily involved in the Educate, Test, and Treat program. We have also some. We have actually extended to other key populations such as LGBTQ and people with sexual risk, and through the NC initiative, through a platform for National Foundation of Digestive Disease in collaboration with the Pink Dot, and we plan to work with hepatitis C mobile testing service action for AIDS anonymous testing service also in the next year in 2024. We are also in the discussion with the Institute of Mental Health for the program in addictions detoxification program. And currently, we do have some stable program for hemodialysis surveillance and also pregnancy and surveillance in the pregnancy and also the HIV cohort. And while for the general population with the risk factors, most is actually, we are using the outreach, the public talk in terms of annual work. There's Day Public Forum, in which is actually an annual event, and also we plan to have actually interesting perception survey in the young Singapore adult from Hep B and Hep C in next year. So, however, we don't have any active screening for the blood transfusion before 1992, and there's no active screening for the foreign workforce at the moment. So my talk today will actually concentrate on the PWIT group in the Halfway House, which is actually a community-based corrective institution. And the program highlight here is actually we do have some component on the education, diagnosis, linkage to care, and also treatment. So if you can remember the slide from my slide from the APASL February 2023 Policy Forum, and Halfway House is actually fall under the aftercare of the Singapore Prison Service, and we, through the collaboration with HCSA, High Point, and my hospital, Tan Tock Seng Hospital, through the Educate, Test, and Treat program, has enabled us to actually, have a chance to see what is actually need to be done for the Hep C elimination in the PWIT group. And this has also primed our interest to generate the NC initiative through this opportunity. So, what is actually the program development for the ETT? So we have made great progress in ETT with a recruitment starting the recruitment drives since 17th of March 2022. Then we followed by the official launch of program in July this last year. And this was actually followed by the participation of other Halfway Houses such as Teen Challenge, Tularang, and also the Helping Hand. And we completed the recruitment in April 2023. We analyzed the data that we want to see. And this have been followed by the signing of a memorandum of understanding across 5 major Halfway Houses in July this year to see that Hep C is a national problem that we need to actually address. And from here, there's actually applying the program further. We are delighted to have the Suzy charity organization on board to assist the DAA cost, which is actually still costly in Singapore, and together with an unrestricted grant from the Gilead to support the non-DAA cost. So what is actually the some important outcomes of the report from the ETT program was that we actually reported the Hep C seroprevalence is actually quite stable compared 10 years ago report from the 10 years ago, which is about 37.3%. And we noticed that the ETT is actually not immune from the breakage in the chain of survival of the Hep C elimination. And there's actually a high attrition rate from the RN testing, which is about 53.8%, and the DAA treatment attrition is about 73%. So what is the factors to actually explain this observation of uptake in the diagnosis and treatment? So we quickly analyzed, went through the process, and we noticed that the DAA cost in Singapore, although has been reduced significantly over years, back in 2018 through the value-assisted pricing negotiation by the ACE, 85% reduction in the cost to the patients was achieved. And this is very encouraging, and together further top up with a medication assisted fund has further supported 11% of the cost. And of course, the Singapore government will expect some co-payments, same as the other diseases, about 4%, out from the pocket of the patient. So, however, in this ETT PV group, it's actually a little bit challenging because as well, you can see the immense occupation. The unemployment is about 70%, and those actually, in the social reintegration back to the society, mostly they are engaged with occupation with skill level 1 to 2, and then it's actually encompassed up to about 93%. And even a co-payment, as small as a few $1,000 could be a whole month's salary for many. So, and this have been identified as a major barrier to access to the DAA. As to give you some granularity about the Singapore's finance assistance assessment structure, the treatment subsidy and financial assistance structure in Singapore, the DAA is actually considered as a high-cost medication in Singapore, and we do have a GP and Softwell listed under Medication Assisted Fund, and we have the Softwell box under a separate fund called the MAF Plus with a more stringent criteria. And those actually, to assess eligibility, you need to get assessed from the monthly per capita household income, in which the applicants need to submit documents for those actually staying under the same household, the same address. So, and as what you can notice here, Singapore citizens and permanent residents have a quite different criteria for eligibility, and the patients who cannot afford the co-payment will require a separate social worker assessment for Medifund assistance. So this is what happened if you actually follow a standard workflow. If you can see the green bar, this demonstrated the projected waiting time, the longest waiting time as a barrier to initial DAA from the time a patient is diagnosed with a chronic Hep CV. And the major hurdles here is actually the finance assistance application approval could take up to 5 to 6 months from the diagnosis, and remodeling of the Hep C linkage to the care cascade for an enhanced workflow is actually very required. This is actually what we actually plan to do. Is actually we collapse the blood test to inclusive of FIT4 to identify the patients who is actually have a significant liver fibrosis, and also abdominal examinations to make sure that those actually significant fibrosis is not in the decompensation, together with the interpolation of a liver function test at the first consultation of Hep C clinic. And the background, we don't have a POCT RNA test, but we actually, when the patients come to the Hep C clinic, we did tests, Hep C RNA test, and we trace it at the background. And on the second week, we trace the RNA report in week 2 to initiate the finance application. And FIT4 will guide the FibroScan assessment to see whether the patients actually need a long-term surveillance or not. But this is actually there's no urgency for the immediate completion. So with that, with this care remodeling for ETT phase 1, we are recalling the defaulter, and this is actually a proposition for us to actually proceed to the ETT phase 2. The provider care coordination between the clinician, pharmacists, and finance department, and halfway house coordinators is actually what we're actually looking into. And it will actually aim to actually shorten the chronic Hep C diagnosis or DAA initiation time from 5 months to 5 weeks. And And this, there's actually recent evidence for published by the Australia systemic review meta-analysis. A 45 study described the implementation of the intervention to improve Hep C testing, linkage to care, and treatment station among the PWIT. And the author, have commented that the important point here is actually a point of care antibody testing with a linkage to care and the integrated care in the linkage to care and also the treatment initiation. So what is actually the insight from the ETT program and our future plan here? I would like to summarize the insight and the solution. And we also find that the venipuncture could be difficult and impossible sometimes. It's actually very labor intensive, and there's actually some occupational health has a risk. And we will actually consider the point of care test avoiding a venipuncture if possible. And for the anti-Hep C serology, the current program, Singapore Hep C serology, have fluctuates between 30 to 38%, and it's actually quite stable. And there's actually a model prediction that we don't, just follow the standard pathway without, the care remodeling, that will demonstrate a slow decline in the Hep C incidence without any intervention. We propose active screening for Hep C linkage to care of a treatment, periodical surveillance of the anti-Hep C serology for those actually have not exposed to Hep C before. And for those actually defaulted the Hep C RNA testing because of a complex social behavior background, and also a recidivism rate for the drug-related offense remains significant over the years. And we think that we need speed. And for the early confirmation of a chronic Hep C state and the linkage to care, and this need a lot of coordination with a Happy House coordinator, the support outreach education program for the awareness. And for the chronic Hep C, nearly half of the Hep C exposed population in the ETT may remain viremic infectious, with about 50% of them for the data that we have. Without any intervention, we have been actually calculated the PWIT chronic Hep C rate is estimated about 3,000 by 2030. So we should actually upscaling of Hep C diagnosis and treatment later program in corrective institution aftercare program and prison and also halfway houses. And while for the attrition rate from the DA treatment, there's challenges in the finance document collation and complex social behavior background gain and recidivism of the drug-related offense. And for this, we are looking into multiple finance assistance, streamlining the application for the finance assistant and coordinated care with Happy House coordinated support. So lastly, I would like to take the moment to express my gratitude to HCSA High Point staff for their exceptional contribution to the ETT project. So Sean, the head of HCSA High Point, Gerard Wong and Samuel Wong, the senior executive, and also Rary Sosiago, the Hep C SA alumni, a past Hep CV patient who actually get cured with a motivation to join as a force for the current case coordinator, and their constant dedication has ensured the progress of the ETT. I would like to actually share some further insight on the systematic review meta-analysis, published and then by my team on the impact of the direct active antiviral to evaluate the impact on DAA on 5 liver-related outcome: the HCC, occurrence, recurrence, or cause mortality, liver decompensation, and liver transplantation. And we did see tremendous benefit of DAA therapy. If let's say a disease is actually diagnosed early and treated early, and it might not be constantly observed across all groups with different baseline liver status, and we ensure the highest quality possible by only only select the randomized case control and cohort study. We found that DAA reduced HCC occurrence significantly in a non-cirrhotic and cirrhotic, but not in the decompensated cirrhosis, giving us a message that this disease is need to be actually diagnosed and get treated early, and DAA did not actually prevent a liver transplant. And in terms of cost, economic analysis, and cost saving, the ACE have a publication in 2022. And for the subset listing since 2018 in Singapore, the modeling over 5 years, patients called the progression to liver failure, cancer, and death, and the subsidy decision could actually result in the saving of a healthcare cost of 39 million. So my conclusion here is for Singapore, where are we? Hepatitis C microelimination efforts are showing some promising progress, although the economic slowdown and inflation could impact on the program budget. So provision of the financial aid for the medical expenses remain a critical obstacle for us, and multiple funding sources are needed to ensure access to medical care, to ensure them is actually remain affordable. Although equitable to healthcare access is very important, but there's some consensus approach that should be taken to address any potential sensitivities involved. Thank you for your attention.
Thank you for an excellent presentation. Great and very interesting to hear about the status in Singapore. So thank you for bringing that to our attention. You mentioned the subscription model for hepatitis C treatment, whereby at one cost you can treat a unlimited number of patients. That's typically the case. So that really helps solve a problem on a budget for the treatment. I'm interested also in the your approaches to preparing the workforce to deliver that treatment. What's the role in training that you put in place to and were primary care doctors as involved as specialists were in the delivery of care for hepatitis C in Singapore? Thank you. So were there any particular challenges in training non-specialists to provide treatment for hepatitis C in Singapore as part of this program?
Yeah, sorry, Prof. I can't, because of connection problem, I can't really hear you just now.
Okay.
Okay. Yeah, so now it's actually clearer. Yeah, we do have some, training program. I would like to actually divide it into the halfway houses. Because we are actually using the HCSA High Point as the model for us to actually build as just a pilot in which we are training our HCSA coordinator Larry to go through the process by accompanying their clients to actually come to the hospital and then hold hand with them. And we did actually going down at a regular basis to the halfway houses to give the talk. And to actually have engagement with all the halfway houses, the personnel, and we actually just also actually in the process of the discussions of whether they can incorporate Hep C elimination, the program, education program into their routine kind of the aftercare program in the halfway houses. And well, for the general practitioner, it is mostly actually driven by the individual hospital to actually organize a yearly event to actually engage the GP, the general practitioner to actually choose a topic on the Hep C elimination. But Singapore is actually very small. I think as compared to the bigger area like the Australia and the US, and then probably it's actually because of the logistic issue that we actually it's actually beneficial if let's say we can generalize just like Taiwan to the GP and also non-level specialists to actually prescribe DAA. However, in Singapore, because the population is actually also relatively smaller, and the population is actually in the vicinity to the hospital, to the major hospital. At the moment, we still haven't actually generalized the GP, but we did actually have some engagement with them for referring the cases, and then we actually there's some program to allow the reflex testing at the GP level. Thank you.
Thank you. Thank you so much.